I know Ray and I have several questions for you, but there's a couple of microphones here, and would really love to hear any questions or comments or experiences that you would bring to bear. Just a show of hands, how many of you have already been engaged in some kind of global surgery experience? Great. And how many of you intend to be involved in such an effort over the next 12 to 24 months? Great. Good. Wonderful. So a question just to start, and again, if there's anything that you've heard a lot of very compelling presentations. A question I wanted to put to Paul and to Sherry as a starter, like each of your responses on this. So you can't really prepare for the scene like you showed Paul after the earthquake in Haiti. So how would you suggest folks kind of work their way in? We'll have a real cross-section of experience here between folks who've just had a taste of global surgery versus those who've been doing it for a long time. How do folks not get overwhelmed? How would you counsel somebody to get involved and not just be completely overwhelmed in the context of what you've done? And then Sherry, I'd like to hear your piece on that.
Sherry should go first on that because the overwhelming part is disaster. So.
Well, no, I'm going to push back to you, Paul, because I think that the overwhelming part can be when you're on call in a low-resource place and somebody's coming in and obstructed labor.
Okay. Well, first of all, we're surgeons. So, you know, being surgeons, I think we should have had, with our training and residency program, been in many situations where we did see a lot of overwhelming things, and we got through it. And that's going to help us when we first volunteer to go somewhere else and help. But I think that you know, you're going to get through it because usually if you join with a team and you're with other people, you know, you're not going to be prepared for a lot of what you see at first, but the frightening aspect also becomes exciting aspect, and later when you have a chance to reflect on it with the rest of your team at the end of the day, at the end of the trip, it's a pretty amazing experience, and I think that it's going to be one of the reasons why you're going to want to go back. I don't think it's for everybody, but surgeons are kind of built for this. I mean, this is why we became surgeons. We get excited about it, and I think it energizes us. And for me, I've always felt like, you know, a lot of people in life, they have to go on retreats or have to go special places and everything. Not me. I just have to go overseas. It's fantastic. I mean, I get re-energized. Work like a dog, but I come home, I feel better than I ever did.
Great. Sure.
So I think a couple of things. In our home institutions, I would definitely, if you're thinking about going out on a more humanitarian type of mission or disaster even, I would go into the labor and delivery and just watch some C-sections. The beauty is we're surgeons, right? We know how to make an incision, we know how to close it. You just need to know what to do. And you can actually learn that by watching, because you're never gonna be able to get malpractice insurance coverage probably to be able to scrub on those C-sections. Go in on orthopedics and just talk to them and say, you know, boy, you know, if you couldn't internally fix this, how would you do it? How do you put that traction pin in? And so within our own hospitals, we can actually get some of this training that does help. And then I would never discount the people who live in those countries. I have learned so much more from nurses who live in these countries, because oftentimes they're the people who are doing these operations. That's not actually doctors. So nurses and doctors locally, you can learn a ton from. So just be open to it.
Great. A question from the floor?
Hello. I'm Dominic Asman. I'm a third-year surgical resident at Kerr Medical in California. Now that I'm finally past the kind of the halfway point in my residency, I'm starting to think about fellowships. And I'm afraid this is a pretty general question, but what are your thoughts on post-residency training, whether it be in fellowship specifically aimed at global surgery or something like trauma critical care or non-fellowship training?
Ray, you want to take that one?
Yeah. No, so, fantastic question and very apropos. We were on a phone meeting yesterday with Guillermo Tefera from Operation Giving Back and another small group where we are trying to put on a meeting at the American College of Surgeons this fall that will be inviting people who are running academic programs for global surgery and those interested in developing those kinds of programs and trying to figure out ways that we can support the development of those. And I was just thrilled to be able to barge in on the Methodist Hospital program that they gave a global surgery grand rounds this week and learned about their global surgery fellowship that is a 2-year program. The first year of that is after their 2nd year, and the next year is after the 6th year, so really a fellowship, and has a pretty well-defined model that almost like Sherry has mentioned of developing these skills to be able to work in those areas. And I think there's a real need and interest. We've been approached at the University of Utah to develop a rural global surgery tract as well that we're looking at and trying to develop. And I think we would like to encourage this type of development over the next few years. Sherry?
So I have actually just started and have an agreement with an NGO of having a global surgery post-training fellowship. And, you know, I have to say, in theory, it was really great. I mapped it all out in my brain, and then when I put it on paper and I realized how am I going to pay somebody, and, you know, so sometimes it's these specifics, but I think we will begin to see them. I would say trauma critical care is not good training. So when you go into a critical care unit in a low resource country, it might mean that they can check a glucose. So what you're training for, which is complex quaternary ICU care, will have zero bearing. So I wouldn't, if that's really what you want to do, it's a path, and actually we've thought about using trauma critical care, not trauma, it's really critical care as an entry into this fellowship that we're starting. And the reason is that it may be one of the ways to actually fund somebody to be able to do the fellowship is that if they get some ICU time, they can actually then pay for their salary. But the specificity of the training, it's a mismatch.
I think that probably for a while it's going to continue to be an organic process, like you've heard various of the speakers kind of making their own way. Having just been through the resident interview process, we just had the match a week or two ago, but I was amazed this past year how many medical students came through interviewing for our program who expressed an interest in global surgery. We've built a 4th-year rotation to our program, and that has great appeal to an increasing number of medical students, I've noticed.
Wouldn't it be great if we, and I mean by we, the surgical community in this country, could break down our barriers and break down our walls and get our act, and I don't mean this as negative as it's going to sound, get our act together and say, okay, you want to do global surgery when you're done, do your residency, boom, guess what? You're going to come in and you're going to do obstetrical cases, you're going to do C-sections, you're going to rotate in orthopedics, and you're going to learn how to do these things. You may do some critical care time, and do all the things that we talked about that would otherwise be wouldn't it be great if we could do that as a country? Yeah, awesome. And that's kind of, I think, many of our visions. Now it's much easier obviously said than done. But I wish we could kind of get out of our comfort zone and break down some of these silos that we have with training and get a real, and my guess is there are plenty of people like you that would love to do that, and there's a huge need for that, to do those other things and get that training.
I have one other comment as well there, Dom. I think that you should pursue what your interests are at this level, if you're resident level. You should do what you really want to do and you're most interested in. And that's okay to pick it for this country in your interest here, because, when I look at preparing with learning C-sections or whatever, I mean, I grew up in an era where C-sections were part of my life, but that's going to be difficult for a modern trained surgeon. That's going to be more for the applications where you're going to go to a remote location, more likely be a full-time surgeon. But if you're going to be part-time and you're going to enter into largely what we've appealed to you today, and that's education. You can go into anything and you can be an educator anywhere in the world. So it depends. There might not be an application for a highly qualified HPB surgeon in Haiti, but there would be in other countries. And COSEXA or something, you know, there might be applications somewhere else for you. So I think it's mainly that you do what I said it earlier, do what you do best. And then, you know, I'm, as an MIS educator, I'm more in demand now, you know, in a country like Haiti than I would have been if I would have been, you know, in the jungle somewhere doing a C-section. So I think you should just do what you do best.
Thanks. Great question, Dom. And you know, and do your homework. One of the things that, just anecdotally, one of the programs that I go to in sub-Saharan Africa, the most common open abdominal procedure that the general surgeons do is prostatectomy. It's not anything else we do. So things that we don't ever think about. That's the most common operation.
Hi, Andrew Jones from Augusta, Georgia. I'm a fourth-year med student. I'll be starting my internship in general surgery in July in New York. And on the interview trail, I noticed that there were very few programs that offer a full 4-week rotation in global surgery. And most programs typically tend to offer maybe 1 or 2 weeks, and it could be maybe on your vacation time or whatnot. And kind of my question is, what would you recommend someone who is only able to go down for maybe 1 or 2 weeks, how can they maximize their time in that situation and really get the most out of it, and while also, you know, contributing as well?
Ramon, I'm going to hand that one to you. I think one of the quotes that you had was how important trust is, and that you build relationships over time and with repeated visits. And we've had an inclination, well intended, a lot of the time, to go kind of on a medical tourism thing for a couple of weeks. How do you not do that with clearly a different intention from your question?
Yes, sir.
Right. Well, if you only have a couple of weeks, you need to get involved with a program that already exists, or a connection that you already have, say a faith-based organization. You have to think about paying your way down there, because most programs probably won't pay for a medical student or even a resident. We're even questioning paying for the attendings to go down. I'll just tell you, my own experience was in 4th year med school at Wayne State University, we had a 1-month elective. My mother had been involved with faith-based programs in Nicaragua, going down and advocating for peace. And she made a couple phone calls, and I flew down to Nicaragua in 1994. No, excuse me, this was in med school. So this was 1984, and spent a week up in the northern part. This was during the Contra War. In a small town in the Sandinista clinics, seeing patients with diarrhea and cough, and hanging out with volunteers from all over the world. And that experience absolutely electrified me. I mean, in every possible way. Being a European urban kid, this was an amazing experience, whatever your politics were. So when 10 years later, when a surgeon from Nicaragua came to UC Davis and asked his friend at that time, an anesthesiologist, geez, we'd like to learn something about laparoscopy. They called the Department of Surgery, and I happened to be standing outside the door, and they say, Dr. Berger, you speak Spanish, don't you? And I do. And so, yeah, and immediately I heard the word Nicaragua. Oh my God, I'm going back, only because as a med student, I felt like I was learning and I wasn't contributing, and I had just this desire to go back with some tools in my hand. So there are many paths to go, and mine happened to be a personal connection, but I think we even discussed at Go Global bringing residents and students on our trips who could be self-funded in a creative way, because I think you'll get a tremendous amount out of it. Don't worry about what the destination is, aside from security issues, because you will be able to contribute and learn an immense amount.
And almost anywhere you go, there'll be a State Department advisory against going there.
Yeah, yes.
Go ahead.
Hello, I'm Sir Rupakiti from Nepal. And yeah, I would like to first congratulate the Global Affairs for doing what they are doing right now, taking all this minimally invasive surgery to all around the globe. And I'm probably the only CESIS member. I've made a couple of more in Nepal now, and probably the only FLS trained guy. Now, my question to you guys are, I mean, as you go to so many different countries and work there, do surgeries, how do you circumvent or deal with the problem that you may have getting registered with the medical councils of different countries that might have different set of rules for foreign doctors or surgeons coming and operating in the countries?
Ray, do you want to take that? We've got a couple of minutes to wrap up. Do you want to take that one?
You know, it's a great question. Every country has different rules and different regulations. There's different cultures, there's different languages. And it's extremely important to recognize what those regulations are. I have a team that is going to Ghana this next week, and we're lucky enough to have a chief of surgery who's willing to work with us, who is actually over there right now today meeting with the Ensign College of Public Health and with the VRA Hospital to set the stage for my fellow and then a trauma surgeon who's trained in quality and then a quality engineer, as we are going to work with them to help them study their quality programs at the VRA Hospital to see if it can't be expanded throughout Ghana. But to be able to do that, to do the IRB here and then to do the IRB there, there's different rules, there's different regulations. And when we operate in Mongolia, we get licenses ahead of time. In Mexico, we haven't had to get licenses. It's based on the different province and the different hospital. So I think it's extremely important to understand and work within the rules of the places where you work. That really buys you some credibility.
Thank you.
Two very quick questions, and we've got to wrap up, or comments.
Hi, thank you. Erica Kane from Bay State Medical Center. Currently working with one of our attendings at Bay State to develop a Haiti rotation for us. And there's already a little bit of pushback. I know it's a lot, there's a lot of difficulty and many obstacles. I was wondering if you guys could speak to any of the obstacles that you've encountered or sticking points, either in your divisions, at your hospital, or with the ACGME, how to get something like that moving.
So that's a great final question, and I want to make that, and then I'm going to add one addendum to that question, and then we'll end up with that. I want to hear from everybody in the panel. So, obstacle you've had to deal with, not wherever it is. A B, in terms of personal items on a checklist that you would want to share with our colleagues here, what's one of the most unexpected things that you just found that you didn't have and you really needed that you wish somebody told you about on the first trip that you went to a low resource setting? So, no, you're asking about were you asking about obstacles to restate your question, if you would?
We're trying to get a rotation, international global surgery rotation, up and moving at our institution.
Oh, I'm sorry. Okay.
But,
all right. Do you want to hop on that real quick? Okay. Then I want to.
So the RRC and American Board of Surgery, because you actually have to get it off both sides, it can be an interesting process. I think there's a number of people in this room who have an RRC-approved rotation. One of the biggest obstacles is who is the on-site supervisor. So the stipulation is an American Board of Surgery certified surgeon or their equivalent. So for our rotation, I was actually able to argue, we have a professor at Zimbabwe, because he had a fellow of the Royal College of Surgeons of Edinburgh, I said, well, that's clearly an ABS equivalent. And the RRC actually agreed with that. So we have an African supervisor. So we do not have to have this, an American has to be there and all that. That makes that type of thing so much easier. The other trick that we found, it's funding. My nightmare is, how do I fund this? So we actually went to our GME office. The hospital gave us money. The CEO of the hospital gave us money to be able, and he just renewed, we have a new CEO and they just renewed it again. So our CEO of the hospital has diverted money from the hospital to fund this part of our GME program. So we do require a minimum of 4 weeks, because otherwise it's just not enough, and that's actually what the RRC does. All of us share our applications. I can't tell you how many people have asked me for ours. When I was putting it together, I asked for Tarpley's. I mean, it's a world where almost all of us will share our applications, but the supervisor is the critical piece you have to figure out.
Okay, just to wrap up, I'm going to go back to my question. What's the one thing that you want to tell folks heading out that they might not have think, but in terms of the personal checklist, not the organization you sign up with and all that stuff you went through?
Boy, on a personal side, I mean, you just have to get used to cold showers and so forth. But in laparoscopy, the little Achilles heel that no one predicted was to have the right adapter for the CO2 tank. Because you go down there with your American CO2 tank in your head, and they wheel in some industrial CO2 tank, and it doesn't fit your insufflator. So if you're taking laparoscopy to the developing countries, make sure you have the right adapter for the tank.
Sherry?
I think personal considerations, always make sure you go to your travel clinic well in advance, not the day before. And always, there is a healthcare worker website where you can look at the risks of the country, because you do have to be aware in some countries there is a great personal risk to you as a healthcare worker, especially if you have an American passport. So educate yourself before you start going places.
Thanks, Ray.
A sterile, you there? A sterile thumbtack. When we were massively bleeding from the anus from our large rectal cancer, and the anesthesiologist said, "Ray, there's no blood pressure up here." And we held pressure while they went around the city of Ulaanbaatar to find blood for 2 hours. My nurse finally remembered that we saw a thumbtack on the bulletin board on the way in, so we had 2 hours to wait. We sterilized it and used it. I wish I had one with me.
Great.
So I'm going to stick with personal items. Granola bars. And the other one is actually Ohio State National Championship hats. True story. We brought a whole boatload in, the kids and the people. You want to win somebody over in about 10 seconds? That was the way to do it.
That's good. Paul?
Right here? Yeah. Am I there yet? Yeah, I regret that I didn't have enough tennis sweatbands for the non-air-conditioned operating room. I needed a lot of those, and I sweat way too much. So the next year we donated air conditioners.
Great. All right. Well, I want to thank you all for your attention, and the speakers and my co-chair. Thank you so much.